Well, we are live and we're in the same room. This is weird making eye contact with you. I looked up from my computer. This is funny. Well, this is actually gonna be way more exciting, like a real,
more dynamic.
Yeah, real podcast, probably more dynamic. If you're joining us live, we were a little late because we were figuring this out, but hopefully it's smooth sailing in the future. So today's a pretty exciting episode. It's definitely more broad than some of the ones we've done in the past, and it's called Decoding Your Normal Labs. So a lot of patients come to MedMatrix with the kind of key complaint that, you know, they go to their normal doctor, PCP, whatever, and they're told their labs look fine when they don't feel fine. They're told their labs look normal. So we're going to be jumping into, like, you know, why that actually is and kind of how we take a different approach with functional medicine to really focus on what is optimal for the patient and how we do that, right? So this is going to be, I think, eye-opening for a lot of people, especially if, you know, you're that person who's like gone to your normal doctor and like you want to feel healthier, especially if you're like trying to do the right things, you're going in the gym, you're taking supplements, and you just like don't feel like you used to. So it's gonna be a fun one. This is for educational purposes only. Don't, you know, take this as medical advice. If you want medical advice, you're welcome to become a patient. You can go to medmatrixusa.com and talk to a patient coordinator, see if we can help you. But with that said, Dr. Rose, why don't you give a little intro and kind of like how you got into functional medicine and your experience. Yeah, let's hear it.
Yeah, I'm Dr. Sasha Rose. I'm a naturopathic physician and a licensed acupuncturist. Been practicing for 20 years. I sit on the Forbes Medical Advisory Board as one of the experts. And I was drawn to functional medicine because I find that it is backed by science, but it is not kind of constrained by old beliefs.
Okay.
It's kind of a really nice mix of continuing, like constantly like looking for more answers, root cause medicine, as we like to say, and based in science, backed by evidence. So that just resonated for me from the beginning.
Okay. Can you explain what you mean by that? Because like a lot of patients, like they think kind of functional medicine is like woo-woo, and they think conventional medicine is the only real scientific way to like go about healthcare, but like that's not true at all. Like, can you explain explain the merge of functional medicine and still conventional medicine?
Yeah. The way that I see it is that if anything in functional medicine, we are doing more testing. And we are, we're doing blood work, we're doing, depending on the test, we're doing salivary testing, urine testing, stool testing, and that we're constantly kind of, in my experience, based on going to conferences and doing lots of continuing education, we're always kind of asking more questions and digging deeper and looking at the research, combining it with our own clinical experience and kind of innovating.
Okay.
And this is, I fully admit, somewhat of a biased opinion, but I feel like conventional medicine, because of its constraints with insurance, because of its constraints with, and maybe influence from pharmaceutical companies, doesn't move as fast and is sometimes impacted by ideas and scientific beliefs that are actually not current. It just takes longer in that conventional medicine system for things to actually change, for like people's providers, doctors, clinical practice, for what they're doing to actually shift. And I think that anybody that I've worked with in functional medicine, like, we're always doing more research, and we're always, again, going to conferences and making our own, decisions based on the studies and on the research and where the information is coming from. So it's like, it just feels more, just to use the word again, like more dynamic, more kind of in tune with not just what people need, but what the most recent research is telling us.
Yeah, totally. Can Can you give like an example of a way that like conventional medicine has kind of fallen behind and, patients are coming to med matrix and functional medicine and like getting ahead of the curve with medicine, if that makes sense? Like, yeah, that was a good point you raised.
Yeah. So here's something that comes up pretty frequently in my own practice. It has to do with hormone replacement therapy. And the thought, I would say, has been, or up until recently, and still is embedded in many areas of conventional medicine, that if a woman is 10 years postmenopausal or over the age of 65, that it is not safe for her to do any hormone replacement therapy. End of story. And those of us who practice what we call menopause medicine, hormone replacement therapy, specifically bioidentical hormone replacement therapy, we know that when estradiol, for example, estrogen, is administered topically or transdermally versus oral, and when it is bioidentical, not synthetic, that it is completely safe for a woman who's over 65 or 10 years postmenopausal.
Okay. So,
so here's an example. I will have patients come in who are, say, in that category. They're over 65, they're 10 years postmenopausal, and there's reasons, which I won't go into right now, why the two of us, me and the patient, feel like it's worth exploring putting her on some bioidentical hormone replacement therapy. I will always tell her what I know from the most recent research, and based on what I have learned and what I am continually kind of keeping on top of. And I will tell her it's possible that when you go tell your primary care doctor that you're doing this, that they will freak out. And just so you know that, and I'm giving this advice based on my education, what I've seen, what I'm studying at this time, and just so that's an example, I guess.
Yeah. Okay.
It's like an old way of thinking, and we're all guilty of that. Like, we're all guilty of, like, we were taught something, and we stay in that mindset. Yeah.
Okay. Thank you. What outcomes happen when you start to think outside of the box with patients and really look at patients like an individual, like the example you just gave? You know what I mean? When you start focusing on things that really do matter, like hormones and so on and so forth.
So, the classic example is somebody who has been dealing with hot flashes and night sweats for 15 years, but now that the FDA removed the black box warning on estradiol, she's interested. She wants to start estrogen, but now she's been told that it's too late for you. But she's still suffering, right? And we know that there are still benefits to her in terms of improving her, lowering her risk of dementia, cardiovascular disease, etc. She still is going to have some benefit from that. I think that answers your question.
Yeah, totally. I guess one thing that I think a lot of patients wonder is how can you go to your doctor not feel fine? Like, you're lethargic, you're not sleeping well, you're overweight, you have joint pain, anxiety, they're giving you all these medications, and then your lab work comes back as normal. Like, how is that? Like, how can you not feel great, but the labs look totally fine? Right. Yeah.
So two things. One is, what are they testing? What are the actual labs that they are offering? And again, sometimes that's limited by what the insurance will cover and or just the knowledge of the provider. Also limited somewhat by, I think, and I've said this before on this podcast, that literally the time of the visit, the time that provider has with you to really look at you as a whole person, ask about the quality of your sleep, ask about your stress level, ask about all the questions, all the lifestyle questions. There's literally just not that amount of time in a visit. And there's these constraints in terms of what's the insurance going to cover and just the training and the expertise of the provider. So there's that kind of limitation. And what is, and this is kind of what we always come back to, and a big part of this podcast today is what is normal,
right,
versus what is optimal.
What is normal labs? Like when you hear like, oh, your labs look
Yeah.
normal, and you get the blood report and you see the little range or the sliding scale, and everyone's different.
Yeah.
Like, how do they come up with that normal range?
You will notice also that like different labs will have different reference ranges. So it's based on statistics. It's based on certain group of people, demographics. Some of the people within that pool have disease and some people don't, but it's basically just a statistical reference. So it includes people in all states of health and honestly all ages.
Right. So, when you're being told you're normal, you're being put up against someone who's really unhealthy.
Yeah. So one way that I think of it sometimes is like, you might be within normal, but is that really where you want to be? Like, unfortunately, if you look around in this country, I mean, I can tell, I think anybody can tell just by looking at people, if you go anywhere, that most people aren't super healthy. You can see it on the outside.
Right.
Yeah.
Okay. I understand. What are, I think I want to talk a little bit more about one thing you said, which is the extent of testing, right? Yeah. It's like, a couple markers might look normal because that's all they're testing, right? They're not looking at a whole lot. So like, what are some of the other tests that you think are really important that you like to run on your patients initially, and then kind of follow up testing as well?
So some of the ones that I like would include ones that a primary care might do. So like a CBC is a complete blood count, right? So let's take our hypothetical patient who is tired.
Okay.
Fatigue, exhaustion, one of the most common kind of complaints. So a CBC is going to show us, it's going to show us a white blood cell count, but it's also going to show us a lot of biomarkers around red blood cells and hematocrit and hemoglobin. First, if hematocrit and hemoglobin are low, that's an indicator that this person potentially has anemia.
Okay.
Iron deficiency anemia being one of the most common. Also B12 and deficiency anemia is another one. So CBC, that one is done kind of somewhat regularly. Comprehensive metabolic panel is also one that's maybe done not as often as I would like within kind of conventional medicine, but it is done. And that's going to show us your fasting blood sugar, your liver enzymes, your basic kidney health, your electrolytes. And then conventional medicine will also, this doesn't really relate to fatigue, but like a lipid panel.
Okay. That's
usually about it in terms of what I've seen other providers run. They might run what's called a TSH, or a thyroid stimulating hormone, if they are wondering if your thyroid is out of balance. What we at MedMatrix like to see is everything I just mentioned, and a complete thyroid panel. We can get into that a little bit more later if you want, but it's not just the TSH, it's the actual thyroid hormones.
Yeah.
It's the antibodies to see if the person has an autoimmune condition called Hashimoto's, which 80% of people with hypothyroidism, it is Hashimoto. So
80%?
About 80%.
Wow.
And then we do micronutrients, which again, that's not traditionally run. So we're looking at someone's vitamin D, their B12 level, their folate level, not just iron, which can fluctuate a little bit more day to day, but ferritin, which is your liver's ability to store, or the reserves of iron. That's a much better test than just your iron. So we have these micronutrients, and then we have these kind of panels. Yeah. And then we've got cortisol, right? So that's if somebody is not sleeping well, they're stressed, they're tired, that's an important marker. And then of course we into kind of the sex hormones as well. And if there's an imbalance there, that can contribute to all sorts of things. Hormones are rarely tested within conventional medicine. Sometimes if somebody asks, their doctor will order them, but usually not. And again, there's a normal versus optimal for a lot of hormones too.
Sure. Yeah, that's a good point. Let's talk about each one of the subjects for a little bit longer. I guess like thyroid's a big one that comes up a lot. Like what you kind of teased this a little bit, but like what is a full thyroid panel?
Yeah.
And like most patients aren't even getting, like why does it matter? Like most patients aren't even getting, their doctors aren't even telling them about this.
Right.
Yeah.
So oftentimes people, and again, maybe if somebody is fatigued, they will run a TSH, but it's not part of a regular panel.
TSH is just part of it, though.
Yes. So our panel it includes thyroid stimulating hormone, and it also includes T4, which is basically the inactive form of the thyroid hormone. If you're watching or listening and you or somebody who's on a medication called levothyroxine or Synthroid, that is T4.
Yep.
It's basically the inactive form of the thyroid. So we test levels of that, and then we also test T3, which is the active form. We test reverse T3, which is kind of this inert competitor to T3. If that's too high, that's kind of kicking T3 out of the way. It's not letting T3 lock into receptors. We also do thyroglobulin antibodies and thyroperoxidase antibodies. Again, answering the question of an autoimmune component. So that panel is really thorough because it's not just do you have hypothyroidism or hyperthyroidism, which is a lot less common, but that here's the TSH. But okay, let me finish that thought. But it also tells us, like, if you have hypothyroidism and you're on a medication, are you on the right medication? Are you, there's an issue with conversion. T4 has to be converted to T3. Is your body doing that optimally? Maybe your T4 is normal, but your T3, which is the one that's actually doing the work, is suboptimal.
Okay.
So we wouldn't see any of that with TSH. We also wouldn't see if you have Hashimoto's or not. We would just see if the TSH, where the TSH is. So those are some kind of common examples. TSH is a really good example of kind of normal versus optimal. So on the lab that we use, the normal reference range is 0.5 to 5. So for conventional medicine, you could be at 4.99 and you're normal. In functional medicine, we have a more narrow window of what we consider to be optimal. So again, normal versus optimal. Optimal is usually in the ballpark of like 0.75 to 2. So if you're outside of that, you don't necessarily have an actual diagnosis of hypothyroidism or hyperthyroidism, but we know that you're like kind of borderline, it's maybe the beginning of one of those conditions. Again, usually hypothyroidism.
Okay.
And we always piece together the lab values and the symptoms and signs of the patient. So it's not just chasing lab values.
Yeah. Is that something that you feel like is missed in conventional medicine a lot? You mentioned like the visits are quicker. Like
it's missed, one, because say somebody comes in, they're really tired and the doctor does order a TSH, and again, it comes back at like 4. They're going to say, you're fine. I'm going to say, you're fatigued, your hair's been falling out, you can't lose weight, and your TSH is a 4. I think that's pretty much a hypo or a borderline hypothyroid state. Like that warrants intervention. Okay.
Yeah. And then talk about like the way that also, because it's not just about like normal versus optimal lab rations, it's also about like the solutions that then
what are right. So it's not just right. So what's in the toolbox? It's not just levothyroxine. Right. It's like I when I work with my patients, I don't like to tell them what to do. I like to give them a menu.
Yeah.
And I'm only going to recommend things that are safe, that are backed by science, that I've seen actually work. But like in this case, there's more than one thing that works. So yes, levothyroxine or Synthroid is an option. There's another prescription called Tirosint that people sometimes do well on when they haven't done well on other ones. And then there's like a natural alternative. I use NP thyroid, which is like a combination thyroid product. So, and we have the ability not just to prescribe T4, like with levothyroxine, but to add in a very small amount of T3. So it's really like they're all potentially good. Sometimes it's trial and error. Let's start you on a low dose of this and see how you do. We retest in 3 months.
Yeah.
And let's see, A, how you're feeling, B, what your follow-up labs look like.
Okay. Gotcha. I got a good question here. So we're going to move on from thyroid. I think we're going to do we've done episodes in the past that dive really,
we could do a whole nother episode on it.
So if you're listening to this now, you're listening live or you're listening to the recording, just go check out the podcast and listen to a thyroid episode. But we got to keep it moving here. So one of the things is blood sugar, right? So blood sugar is another example where normal doesn't really mean optimal. So like, what are some of the metabolic markers that might signal early insulin resistance before diabetes develop? And like, how does functional medicine approach things like diabetes and, A1C differently than, your normal doctor would?
Sure. So again, on our initial panel, we include both insulin. This is a fasting lab, so both insulin, which it does matter if you're fasting or not, and then hemoglobin A1C. It doesn't really matter if you're fasting. So insulin is the hormone put out by the pancreas. It helps glucose to be directed into the cells.
Yep.
Hemoglobin A1C is a 3-month marker, 3-month average of your blood sugar. So it's a much better marker than that fasting blood sugar that's included, because that's just a snapshot.
Yeah.
So your hemoglobin A1C, it's calculated in percentages. So anything, again, according to conventional medicine, anything under 5.7% for hemoglobin A1C is considered fine, normal. Once you're at 5.7% to about 6.5%, that's considered pre-diabetes. And then over 6.5% is diabetes.
Okay.
So again, if you're at 5.6%, not all, some conventional medicine providers would be like, you're fine. And we see that as kind of like potentially a pre-diabetic state, right? So ideally you're closer to 5.2%. I had a patient today who we wanted to revisit that. She had seen her original blood work with me back in October, and of course it included the hemoglobin A1C, and she was 5.6 at that 5.6% at that time. And she has been making some dietary changes, some lifestyle changes, and so she's coming to us because she's being proactive with her health, and she doesn't want to become pre-diabetic. So we are, every 3 months we're checking it, we're monitoring it. Insulin, if you start to get into that insulin resistance stage where the receptors on the cells are no longer responsive to insulin. Okay. Blood sugar has been too high for too long, and therefore insulin has been too high for too long. The cells kind of stop responding. They're just not sucking it up as much. And so the pancreas puts out more insulin. Okay. Same thing. If your insulin is at like 17, if a doctor were even to test it, if your insulin was 17, that would be probably considered fine. I see that as like you're on your way to insulin resistance, because once you hit 20, then you're technically insulin resistant. Okay. And can you like come back from there? Or is it really hard? Absolutely. Yeah. So lifestyle, a lot of great tools, but some of the things that most people know, which is, lowering your glycemic load, moving your body, regular consistent exercise. And then we do have some tools like peptides, like GLP-1s, and potentially other nutraceuticals that can really help with that. Heard. Okay. All right. So we're kind of moving on from like area of the body to area of the body. So we've covered thyroid, blood sugar. Now let's talk about a little more about sex hormones. Like, how are sex hormones, like, first off, for people who don't know, like, what are sex hormones and how are they looked at differently in a conventional versus functional lens? So sex hormones are, I'll just list them. We have the most common, the ones that we hear about the most would be estrogen, and the ones that we test, there's 3 types of estrogens. The strongest one, and the one that we test for on blood work, is estradiol. So that's what is tested, and much of the time, if you're going to be like, say, on an estrogen patch, you're taking estradiol. Progesterone, testosterone, and then we have some additional ones in our panel, follicle stimulating hormone and luteinizing hormone, as well as prolactin. So those are all considered kind of sex hormones. Again, not routinely tested in conventional medicine unless, say, you are going through infertility, you're having a hard time conceiving, you're a woman having a hard time conceiving, or you're amenorrheic, meaning you don't know why, but you're not getting your period. So other than those situations, those sex hormones aren't usually tested. What was the second part of your question?
Why are they so important? Like, a lot of people actually don't even, like, they're not getting tested, their doctor's not talking about them, and they feel like shit, for lack of a better term. And they're not even talking about sex hormones. Like, why are sex hormones, how do they play such a role?
It isn't. So I'll just use kind of, a lot of the people that come to us are women who are, say, over, between 35 and 60, 55 or 60. So they're either entering perimenopause or they're actually menopausal, somewhere in that window. What we see is that, I can look at those results and I can see if a woman is still cycling or not, just based on those hormones. I haven't even met her yet. I can just tell if she's still having a period.
Mm-hmm.
In the same way, I can tell if she's actually postmenopausal. Now, when you're perimenopausal, so that 10 to 15 years before you actually stop bleeding, it can be all over the place. So your estrogen level might drop, your progesterone level might drop, but your ovaries are still producing them. Mm-hmm. And the fluctuations might be kind of changing. And so we're kind of trying to get a baseline with that. Now, the American College of Gynecologists, that kind of standard of care doesn't usually include testing for the perimenopause or menopause state. They will prescribe, or they will say that it's okay to prescribe hormone replacement therapy without testing. I do agree with their line of thinking that we're largely doing this. We're largely prescribing on symptoms, signs and symptoms, and what we know to be like the preventive reasons to do HRT. But the value of baseline testing and then monitoring while somebody is on HRT is, yes, in addition to how they're responding symptom-wise, but we can see the levels changing in the blood, and we can kind of match their symptoms to this blood.
Sure. Yeah, it gives you like a point of reference.
Exactly.
But what about women who are postmenopausal, right? Because you can tell when a woman is postmenopause based on her blood work.
Right. So basically, there's no progesterone, there's no estradiol, and actually her FSH and her LH go up.
Heard. Okay. And let's not forget the guys. Let's talk about the guys. Let's talk about the guys. Like, okay. So then we've got. But there's a lot.
And testosterone is a female hormone. It's not just a male hormone.
Yeah. Let's talk about that. Okay. We'll talk about that before we move on to the guys. Okay. Because a lot of women just think of testosterone as it's only important for men. But
everybody thinks of it that way. We were taught that.
Yeah. So like, why is testosterone so important in like just the way a woman feels every day?
Yeah. So women actually have more androgen receptors than men. So androgens is kind of the category of, like, testosterone falls under the category of androgens. So we, just like we have estrogen receptors everywhere, we have testosterone receptors everywhere. Testosterone is not a menopause, it doesn't shift with menopause. Testosterone in both women and men starts to decline actually in our 30s. And it's more of like a slow, steady drop. Mm-hmm. Now, of course, there's situations when, like, I have one patient a male patient who had some kind of testicular torsion when he was an adolescent. And so that, situations like that, like he's had low testosterone for
sure. Yeah. That's a structural thing.
Right. But other than those situations, for all of us, it's just aging, and literally aging when we start in our 30s. So it's not unlike progesterone and estradiol in women that kind of goes like this in perimenopause, and then it's like off the cliff in menopause. Testosterone has just been continually declining. Why does it matter for women to have optimal levels of testosterone? And I should note that is, we do a full testosterone panel for women as well, not just men. Okay. So women need optimal, not normal, optimal levels of testosterone for cognitive health. So for those symptoms of brain fog, for example, word recall, overall drive and motivation, including libido, including sex drive. Some people say that, or I have heard some experts say that low suboptimal levels of testosterone in women can basically make a woman unable to have an orgasm. So if you kind of optimize that, she gets the ability to have an orgasm back. That's one reason why optimal levels of testosterone can be beneficial. One thing that I talk to my female patients about a lot is the physical benefits of optimal testosterone. So muscular health, muscular health, strength, mobility, balance, and how that translates to bone mineral density. So I feel like I'm a bit on a mission to kind of change the mindset around women and testosterone.
That's funny. I mean, if it sounds like it makes a pretty big difference.
Yeah,
so
yeah.
And
it's like everything. It's not like every woman should be on HRT. Not every woman should be on testosterone. But,
right.
Yeah.
But yeah, if it's something that like you're going to your doctor, you have no libido, and you're losing all your muscles, and you just got no like motivation, and they're not even looking at that. You know,
they're not looking at it. It's not FDA approved for women.
Right. So you would.
It's kind of off label. And for those patients who are on a GLP-1 medication, one of the potential side effects with those is some loss of skeletal muscle mass.
Mm-hmm.
A very low dose of testosterone can be one tool to help maintain that.
Okay. That's awesome. And that's a cool thing you get to do when you see providers like yourself. Because I think a lot of, there is kind of the whole world of like the online, like the hims and hers, and, you can get a GLP-1, but
there's no other support.
Right. Yeah. They're not looking at the full picture. Right. All right, and we got to talk about the guys for a second,
let's get back. Sorry, I'm so woman centered.
That's all. It's all good. But like with the guys, it's talked about more, right? Testosterone is something that's like we've all known. Like you think about guys, you think about testosterone.
If a primary care, if a urologist tests testosterone in a man, it's usually total testosterone. We do what I think of as a complete testosterone panel. So it includes total. It includes something called sex hormone binding globulin, or SHBG. So this is my little spiel on this. This is a protein. It's floating around in the blood along with testosterone molecules. It's like a bit of a sponge, this protein. When it attaches itself to a testosterone molecule, it kind of soaks it up. It renders that testosterone molecule inactive so that the testosterone can no longer lock into a receptor.
Right.
Therefore, the higher your sex hormone binding globulin, the less of your total testosterone is actually doing anything. So I had a patient this afternoon who had, for his age, early 60s, pretty high level of total testosterone, like over 700. But his sex hormone binding globulin was also really high. So then what we have on our test is we have a test called free testosterone and bioavailable testosterone. And those are telling us what's the body actually able to tap into. And that's a more accurate read. So that came back as low. His bioavailable testosterone was actually low, even though his total was high. So you're not going to catch any of that.
Gotcha. What were his symptoms? Like, was he tired? Did he have low testosterone?
Difficulty, like physically, like super fit guy, like super physically active, but feeling despite that, like he's losing muscle mass.
Gotcha. Interesting. Okay, cool. Now let's talk about kind of last segment here, gut health. How does like conventional medicine look at gut health, or how does functional medicine look at gut health differently than, conventional medicine?
So that's a kind of a big topic. So usually I would say within kind of primary care, if somebody's not feeling well, they're either constipated, they have bloating, that kind of thing, they might be told to go on Miralax, right? To do like an over-the-counter laxative. Now, if they're having, if it's something more acute, like acute diarrhea or something, they will do like an appropriate workup for some kind of infection, right? So they'll do a stool test. They'll kind of make sure that but I'm talking about chronic gut stuff.
Yeah.
And then, so sometimes they'll say take a probiotic, take a laxative, maybe depending on the knowledge base of the provider, maybe some referral to a nutritionist or some dietary recommendations. And then usually if nothing's working, then they're referred to a gastroenterologist.
Okay.
The extent usually from gastroenterology is colonoscopy and or endoscopy. And I find those tests to be super valuable. I refer people to those all the time. What we do in functional medicine does not take the place of those screening tests or those scopes, basically. But what we do is we will do a very comprehensive stool test. And so that is looking at parasitic infections, viral infections, bacterial infections. It's a very thorough H. pylori test. Actually, the actual like readout of your microbiome and gut inflammatory markers. If anybody's heard of leaky gut, it has a leaky gut marker. So it's just, again, it's information that you're not getting from a colonoscopy or endoscopy, but it does not take the place of those tests, those screening tests. So that's just one type of comprehensive stool test, but it's the one that I order the most often, and it's just kind of outside the knowledge base, I guess, of most conventional providers. But really, any functional medicine provider should be doing that.
Okay, heard. What about nutrients? Like you talked about micronutrients not even really being looked at on kind of normal screenings. Like, can you give me some examples of like what optimal nutrient levels look like? Yeah.
Yep. So also one kind of connection there is, and maybe we would circle back to this, but is kind of the impact of if there's issues with the gut and if there's malabsorption issues, you are most likely, you're not absorbing those micronutrients optimally. So you might have a fabulous diet.
Yeah.
You might be eating on paper, the right amount of protein and therefore getting the right amount of iron and the right amount of B12. But when we do the blood work, and I'll go over the specifics, like it's not optimal. And you're like, but I eat really well and I get the highest quality food and I'm even, taking some oral supplements, but it's not showing up in your blood work because your gut is not balanced, not supportive.
Yeah, sure. It's a good point.
Yeah.
How often do you find that happen? How often do you find it like patients are doing a lot of the right things, taking supplements, eating good foods, but their gut just isn't absorbing it?
It's fairly common. I can't give you a percentage, but it's common enough that I probably have that conversation a couple times a week.
Okay. And how do you start to, I know we're trying to stay higher level of this, but I'm just curious, like, what do you start, like, what are the things you're starting to look at to like fix absorption in the gut?
Well, I'd like to get that comprehensive stool test because it really gives me specifics on, what is going on with the microbiome and not just is there malabsorption, but why is there malabsorption, right?
Okay.
So what's the level of inflammation and, are they tending to be more constipated, bloated, more on the loose stool, frequent? Like I kind of piece that all together.
Yeah.
So circling back to the question about micronutrients. So vitamin D is another really good example of normal versus optimal. Vitamin D is a fat soluble vitamin, which means that it can accumulate in the tissue, in the fat tissue in the body.
Okay.
So there is a level of toxicity. Now in conventional medicine, if your numbers are really anything over 40, you're supplementing with vitamin D3 and your doctor high 30s, low 40s. They're going to probably tell you you need to drop your dose, or if anything, do not increase your dose. In functional medicine, we consider optimal. So normal might be like 25 to 80 on like the lab's reference range. But that's normal. But optimal is anywhere from like 60 to 80, or I even know some providers that like it 80 to 100.
Okay.
Why does that matter? What we see is that when we can maintain somebody's vitamin D levels within the optimal range, we're seeing improved calcium absorption. We always prescribe vitamin D3 with K2 so that the calcium which is absorbed goes to the bones, not to the arteries.
Okay.
We see optimal vitamin D levels improving somebody's immune strength, so better ability to fight colds and flus and to recover faster. We see mood regulation. We see people who better.
Mm-hmm.
Muscular strength. There's a lot of vitamin D receptors on the muscles. So if you have a lot of vitamin D, you're basically strengthening your muscles.
Okay. What about other key vitamins that you see have a big needle mover?
Vitamin B12. That one again, like the normal level on a lab might be 200 to 700, but really optimal is probably close to like 700 to 1100.
Okay.
Vitamin B12 is one of those ones that is to absorb. They often have compared. If people have a history of alcoholism, they probably have B12.
Mm-hmm.
If somebody is a vegan or say maybe kind of a not super healthy vegetarian, they're probably not getting. If somebody has been living with chronic stress, their nervous system is going to be basically taking up all of that B12 from their food, and they're most likely suboptimal.
Okay. Gotcha. A lot of different things.
Yeah.
So you're going through my notes here. I mean, we normally do, if you're new to this show, we normally do a patient case study, right? But kind of all the patients fall into that range, right? I guess actually, here's a question that I used to get when I was doing the patient coordinator role was, what happens if nothing comes back? People would say, like everything. What happens? It's funny that people actually say that to us. They're like, what happens if I go to you and do all this testing, everything's normal again?
Yeah.
Like, is that even
normal?
Right.
I don't know if I've ever had lab 100%.
Right.
I've certainly had normal.
Mm-hmm.
But even if you're optimal or you're optimal, that's a great baseline.
Yeah.
It's a great baseline because it's entirely possible that in 5 years, 10 years, you're not going to be feeling as good. And then if we test you again and we see that there's a change, we know what's been going on for 5 years. It hasn't been going on for 20.
Mm.
And I have had a lot of people come in or ask me about kind of what we do and interested in coming in, not because they're feeling super symptomatic in any way.
Mm-hmm.
They just want to know more. They just want more information than what they're getting us. Right. They want the numbers. They want to know.
Mm-hmm.
So like it's even if things come back normal, that's peace of mind.
Yeah, that's awesome. Let's still try to do a patient case study. If you can think of someone who would otherwise be told they're normal, like who really struggled with just doctors brushing them off.
Yeah.
That when reality, when looked under a individual lens, is this person, right? And what is their health potential that is actually a big change in the way they felt day to day. If that makes sense.
Yeah, okay. So I will use the because it's just so common. So this is a woman who is in her 40s, and she came in already with they've been diagnosed 20 years ago with I don't think it was Hashimoto. I think she knew it was hypothyroidism.
Okay.
She had been on Thyroid, and they, maybe had felt fine for a decade, but really for almost 10 years, really was still feeling super fatigued, some joint pains, and knew her body well enough to kind of know. She just felt intuitively, at least I'll put it that way, that it was her thyroid.
Mm-hmm.
She go to her doctor, maybe go to the doctor. She would just test the TSH. Within normal, right? Whatever that means, within normal.
Mm-hmm.
So she's frustrated. She comes to us. We do the initial blood work, and her TSH was 3.9.
Okay.
Again, optimal is 0.75 to 2. She, like some of my other patients who, again, had hypothyroidism for a while, have dealt with fluctuating numbers, fluctuating levels of medication, she knows, or she, in her recollection, was that she actually feels when she got that TSH close to 1. So pretty finely tuned, right?
Yeah.
But her providers, for me, were really unwilling to do that because her labs fell.
Right.
So she comes to us at restoration. We do the full thyroid panel. I feel like she needs a higher dose. I also feel like she needs not just T4, but based again on breathing, that she's really not. And it's really when your T3 is low is when you're gonna mostly be symptomatic. So we like to see the T3 over 3. So what I did with her is I actually took her off of the thyroxine and switched her to the more natural combination. Again, hormone, thyroid, and I have conversion, so I could see what a conversion between like the synthetic thyroxine and the natural, and I did the conversion, then I went and saw her. I think that it was 8 weeks later. I saw her retested. TSH was not. It was not quite 1. I think it was 1.8. So she was feeling a lot better. She was like, I think I can feel even better. So we did a little bit more, went up a little bit more, right? And then the next time we did get that TSH closer to 1, her T3 was over 3, and she's feeling good now. So it wasn't that complicated.
That's awesome.
The other thing that I think we found out, because we include the antibodies, is we did find out that that was information.
Wow. What a life-changing thing for someone, right? Because that's the scary thing, right? I mean, that lady might have gone her whole life kind of just getting the same answers from doctors and kind of not feeling as good as she truly could in life, which is crazy thing with, your health. And I mean, your health is, health is like the way you feel every day, man. That's
what else is more important?
100%. So.
And I think the other element of that story is that she was feeling a little gaslit. She knew herself. She knew her body had that disease, the condition, long enough to kind of be able to recognize that at least not entirely.
Yeah, and she knew what she knows what she feels like when she feels good.
She knows when she feels good. She knows when she doesn't feel good. She knows, and yet the authorities, the experts kept telling her, no, you're fine. Your labs are fine.
Yeah.
It's, here's an antidepressant. It's really not your thyroid.
Yeah, I like anything, I feel like when if I had ever had a coach and then, I was in a sports, anything, a teacher, anything in life, the experts, I never want to hear, nope, you're doing good enough. If I'm going for feedback, I want something to work on. I want something to do. You know what I mean? Like, imagine going to a teacher and being like, hey, I want to be smarter. I'm not good enough at math or whatever. Like, well, no, you're good enough. I mean, that's
like you're going to improve yourself, and they're basically.
Yeah, there's nowhere other than life than really like the conventional medical system where people go to get better, and they're told that they're good enough. You know what I mean?
There's no obvious evidence of disease.
Yeah, like imagine you wanted to. I'm trying to make analogies here, but imagine you go to a contractor, right? You want to renovate your house. Like, hey, I want my house to look nicer. I want to make my kitchen look cool. I want these granite countertops and newer cabinets. And contractor comes to your house. Like, well, no, your kitchen looks good enough. You should just it's all good. You just live with it. You know what I mean?
Your fridge works. You're fine. What's the problem?
Yeah, exactly. So it's like, you're food, and so it's all good. So it's just like a weird thing where you don't really see that in other places. But I think that's why patients love coming here, because we can. So many testimonials are just like, yeah, I feel good again, which is pretty exciting. So, that's what we got for time today. We got started a little late because our camera's going out now. that's good timing with the new system. We'll get it down. But anything you want to kind of leave patients with or listening to this, or
one thing that I said before, which I'll just say again, I feel like we all deserve more information about our health, and you might be getting what you want from your current providers at your current what you have right now, but there's this whole other world here where there's just more information, and for most of us it's worth looking into that. It's worth exploring, even if even if you feel fine but you just want that baseline information, it's still worth it.
current? What do patients do if they want to work with you?
Uh,
How patients get started?
They should contact MedMatrix.
Yeah, how do they contact you?
They can call, they can put something, they can DM us.
DM us or website.
You can find us on Instagram.
Yeah.
Yeah.
Yeah, that's it.
Okay. Thank you. Great.
Thank you.